Is it visible?
Yes, sir.
So what is the structure of neuromuscular junction? This is what first we have to understand. It is this is present not only in skeletal muscle. All muscles have got this smooth muscles, cardiac muscles, all of them have this. And they have three main parts. One is the motor nerve ending, which is also called the presynaptic part. The second is the postsynaptic part, which is also called the motor end plate, which is a part of the muscle membrane. And the gap between these two, which is called the synaptic cleft. What is the size of this cleft? Any idea?
20 nanometers. 20 nanometers.
50 nanometer, 15 King Armstrong units. Earlier it was called 15 King Armstrong units, but now they call it as 50 nanometers. Okay, so that is the gap between these two. And this picture will give you an idea. See here, the stimulus comes from here, the axonal part. Okay, and the axon has got this myelin sheath covering and all that. So this part is mainly electrical by exchange of sodium and potassium ions between the exterior and interior. And once the stimulus travels up to that, the first action that produces the change is the entry of calcium through this calcium channels. Voltage gated calcium channels come into that. And they are the ones which are responsible for the release of acetylcholine. So the first and foremost action is by the, so as the impulse comes here and ends at the end of motor end plate, the calcium entry happens. And this makes the, so you can see the first step is the conduction of impulse coming from the axon. Second step is the entry of calcium through the calcium voltage gated channels. The third one is the release of acetylcholine by the vesicles which are already containing the acetylcholine molecules enclosed in a vesicular structure. They come and get attached to the surface here and get exocytosis happens, opens out, and the acetylcholine release is numbered here as 4, and that acetylcholine will go and occupy the alpha units of the acetylcholine receptors at the motor end plate or the muscle membrane, which will make this channel open, make sodium entry happen inside and potassium exclusion going out. That is the fifth step. And this travels on the lateral side also. From here it goes, this depolarization which is caused or the transmission that is caused goes into the lateral aspect, and there also the same changes occur. And then once the acetylcholine is broken down by the acetylcholine esterase, which are present in this small curved area, these blue dots are all the acetylcholine esterases. So they are present in the turf or the bottom portion here. So they come out and immediately cleave this acetylcholine into acetic acid and the choline again, and choline will be taken up back. So this picture, if you remember, is much easier to draw as a line drawing and describe the whole neuromuscular transmission within 5 minutes, saving a lot of time. Okay. So the next thing is, this is a mitochondria where the synthesis of acetylcholine happens. And this is a much simpler picture. So these are all the acetylcholine receptors which are present here. And the cholinesterase will be here in this bottom portion. This is the graph, this is a P. So this is the way the motor end plate is described in a small diagram. And the synthesis of acetylcholine, how it happens between the use of acetyl-CoA. So that happens at the mitochondria above from the nerve ending. And so this mitochondria only help in synthesis of acetylcholine, which are stored in that. And how it is released using the snare proteins and things. Of course, you can write it in your description because it will be difficult to draw these pictures here. So once the acetylcholine is released and the activation is over, the cholinesterase breaks it into acetate and choline again, and choline is taken back. You can see this, and again reconverted into acetylcholine and stored in the vesicle for next use. So that is how the whole process is happening. And this are the steps that you have to remember, whatever I told you. So the first step is the nerve terminal open, calcium ions enter the nerve terminal from the extracellular space. Then increase in intracellular calcium interact with snare proteins, which are responsible for fusing the acetylcholine vesicle to the brain at the synaptic cleft. And released acetylcholine travels to the synaptic cleft towards the motor end plate and binds with the nicotinic acetylcholine receptors. So the same thing given in a larger perspective. So how this is happening, and once the acetylcholine receptors have been occupied, it allows the sodium ions to enter and potassium ions to go out. So there is a change in the negative potential. From minus 90 millivolts, it comes to minus 45, and then it shoots up even to go to the positive side. And on the lateral aspect of what I showed you is done by T tubules, the calcium channels which enter through the T tubules in the muscles. They trigger further action of release of calcium from the sarcoplasmic reticulum, which we saw in the last class. And the remaining acetylcholine in the synaptic cleft get hydrolyzed by the enzyme acetylcholine esterase. And the presynaptic nerve terminal also has nicotinic acetylcholine. These receptors via a feedback system control the release. So that is the purpose of that acetylcholine receptors present in the presynaptic area or the nerve terminal. And you can see this picture will tell you all that. So here you have this is called trough. This is the trough for the bottom portion. And you have the same acetylcholine receptors here also, which control the release of acetylcholine. This one is activating the sodium channels to cause the contraction, and the extrajunctional receptors, which are on the side, away from the motor end plate. Okay, they also get activated to some extent, but they are normally not very active, and they become active only in disease conditions like burns and chronic paralysis or motor activity. And to write the whole thing in a very easy fashion, this is how you can do that in your exam. So the motor nerve fiber sends an action potential which goes to the axon terminal. So opening the voltage gated calcium channel is the first step. Entry of calcium ion into the nerve terminal, opening the vesicles of the release of acetylcholine. So acetylcholine gets released into the synaptic cleft. The passage of acetylcholine binds to the receptor at the motor end plate, postsynaptic membrane. Opens ligand-gated sodium channel. Entry of sodium from ECF. Development of end plate potential. So from minus 95 it creates to minus 50. And the muscle fiber opening of action potential, operation of action will happen. Excitation, contraction, coupling, muscular contraction. So these are all the steps that happen or the sequence of events that take place in the neuromuscular junction, which you can remember for easy description in the exam time. The advantages of neuromuscular monitoring are you can identify whether the patient is adequately paralyzed for a better intubation without trauma or difficulty. And if you are going to use neuromuscular blocking drugs as an infusion to assess the degree of paralysis, whether the patient is coming out and whether it is likely to cause any bucking or coughing intraoperatively, especially during neurosurgeries and cardiac surgeries, it is very useful to monitor that. And during recovery, to find out whether there is any residual neuromuscular blockade before giving your reversing agent, it is very, very useful. And if you do not assess the residual neuromuscular blockage, it can result in inadequate muscle power. The patient has chances of aspiration and pneumonia, hypoxemia, and re-intubation can be required. And also it increases the length of stay and morbidity to the patient. And antagonism dosage and injection time also can be optimized by monitoring the neuromuscular blockade depth. And what are the methods of monitoring that you have to classify? You started off with saying that mechanomyograph and electromyograph and all those things, but it can be classified as first clinical tests of evaluation of muscle recovery is evaluation of respiratory parameters and muscle function. It is 5 seconds head lift and grip strength. So this is the first clinical method of assessing the adequate recovery from neuromuscular blockade. Then the other methods can be classified into what is called qualitative and quantitative method of evaluation. In qualitative, we employ the peripheral nerve stimulation, which is visually or tactily present in the stimulated muscle. And for that, we can use a standard peripheral nerve stimulator. All the descriptions of what are all the nerves that you can stimulate and what are all the muscles that will respond to that, all that is good for gaining knowledge, but not required for answering in the examination. So your learning process should be a balancing act between learning knowledge as well as practicing or getting trained to answer your theory exams within the available time. So in that way fashion, you should try to learn your topics so that it will be easy for you. And the standard method of stimulation, the most useful is what is called the train of 4. And double burst and tetanic, all these things are for deep, very intense blockade where you are not able to get the response for this. Then you use these other methods of stimulation. Okay? And various modes of stimulation, this is called the single twitch. So when you apply a current in an patient, you will get a response like this, which is called the single twitch. And when you use this mode of train of stimulation, the machine itself will automatically deliver 4 currents, which at a gap of within 2 seconds. And in a normal patient, all the 4 stimuli will produce equal contraction strength. And then you produce a tetanic stimulation where there will be a sustained contraction. And then you can produce post-tetanic single twitch stimulation, where in a normal muscle, it will be of the same. See, you can see the height of the contractions are all same in a normal person. Whereas in response to complete blockade, there will be partial blockade only will produce these various changes. When the patient has got no motor blockade, it will be always equal to like a normal stimulation. And in response to partial motor blockade only, you get all the changes. You can see the single twitch is very much diminished in height. And train of 4, this is called the fade. Initial first contraction is very good. And then the second is much less, third is much more lesser, and the last is very, very small. So the height of contraction goes on decreasing, which is called the fade. And after tetanic stimulus, you get what is called facilitation or improvement in the contraction after tetanic stimulus, which is a classical pattern you will see in the non-depolarizing type of muscle relaxation. You will not get this in depolarizing muscle, like saxamethonium use, you will not see it, but all the non-depolarizers like your atracurium, acromium, acromium, all the common ND blockers which you use, they will produce a facilitation when they are partially reversed or partially faded from the block. If it is a total block with complete heavy dose of blockade that you give for intubation, you will not get any response at all. There should be no response, which is indicative of a total neuromuscular blockade. Okay? And this is the difference, time difference. Sometimes they ask you about the duration, the gap between stimulus, all these things. So this picture will help you to describe that. And for the benefit of those who have not seen a neuromuscular blocking stimulator, this is the classical neuromuscular stimulator which is used in the OT for neuromuscular stimulation. Have you seen this type of instrument in your OT, Anthony?
Yes, sir. In plastic.
Okay, plastic. Okay, what is this particular blue and black needles called? I mean, wires
Anode
called?
and cathodes, sir.
Anode and cathode. Any particular name for this tip of this electrode leads? How do you apply them? Are you able to see this in close proximity? Does it have a gap here? Can you see the line here? How do you attach it to the electrodes or the discs that you use for monitoring the neuromuscular blockade? You have to attach or paste the ECG electrodes on the nerve that you commonly we use the ulnar nerve. So you place the two ECG electrodes near the wrist, okay, the above the wrist, the ulnar side, and you can attach this by pressing this red one open up like a crocodile's mouth. So this is called the crocodile clip, the tip of the electrode. Okay, and I'll show you the other type. This is called the ball electrode. Okay, these two are the ball electrode, one red and one yellow. I mean black, and this can be directly pressed on the ulnar nerve. And this is the same crocodile clip electrode. So you can remove this and insert this whenever you. So for a single use, you can use this ball electrode. For continuous monitoring, you can use this. What is called the crocodile electrode. These two tips can be inserted into this. After pulling out this, the red can be inserted into the red and black can be inserted into that. And you can use this like this. Okay, so these are the two types that you have to know. And coming to the quantitative monitoring. So what we saw earlier is the qualitative monitoring. Then the quantitative monitoring only is divided into all these various types called mechanomyograph, electromyograph, and acceleromegraph and kinemyograph. All these things are quantitative monitoring. So they reduce the exact degree of motor transmission, and there is a phonomyography, compressomyography. All these things are various things which are used, and these are all the pictures of how you use them. Okay, so this is the ulnar nerve which is stimulated. As I told you here, you can see this is how the electrodes are placed, and there is a lever attached to that to find out how much of thumb adduction happens. And you always place black in the proximal to the wrist crease and the further down to the black. So black always goes towards the distal portion and red comes towards the proximal portion. And this is the facial nerve stimulation. How you do that? This is the ECG electrode which can be attached, and you can use these crocodile clips attached to that. And this is the tibial nerve, posterior tibial nerve stimulation. So these are the three common nerves that are stimulated, and these are all the various equipments or what we use like electromyograph, kinemyograph. So all these things you can just see how these clips, the crocodile clamp tips are attached to that, to the ECG electrode on the ulnar nerve. And so these are all the quantitative methods of devising that. And they tried this using a BP curve, which we commonly use, the NIBP curve also, for assessing the neuromuscular transmission, which was called the modified cup technique. And that was called the compressor myography, but that has not been proved to be useful. So now it is defunct, it is not more in use. But just in case you do very well in the exam and they ask you, do you know anything about compressomyography? It is nothing but a device that incorporates objective monitoring within the blood pressure cuff, and that will produce also the responses like this in the monitor itself. So that is what used earlier. So these are all the things that I would like to add to your otherwise excellent elaborate description, and you can perhaps short answer, removing the necessary parts and make it into a more shorter version with which you can easily answer in the exam, utilizing the diagrams I showed you in the presentation also. Okay?
Okay, sir.
Thank you.